A few years ago, obesity came out as one of the leading causes of avoidable death in mothers. So, related to that, I've been doing quite a lot of work on obesity since then, in how we can hopefully avoid it, not just for mothers, but actually for the generations to come as well, because pregnant mothers are the ideal people to actually start making changes for generations. So I think it's something that we can all have a major part to play in. So today I want to talk about how we can stop the crisis, and we've had a few conversations already this morning around public health, and actually it's a bit of a Cinderella service in the fact that if you can't find something in this day and age in the NHS that's going to make financial changes straight away, then actually nobody wants to know about it. And I think with obesity, it is something that we need to keep banging on about, because it's not something that we're going to change overnight. Okay, so what is obesity? We know that in the UK, especially around pregnant women, about 1 in 4 pregnant women are categorised as obese, so that they have got a BMI of 30 or over. If you've got a BMI of 25 to 30, you're categorised as overweight. And if you've got a BMI of 40 or over, you're categorised as morbidly obese. Obesity is actually quite a strange term, and when I've worked with a lot of the women that I work with, obesity is the one term that they really don't want us to be talking about. So I quite often talk about high BMI, which feels a sort of a more lame term, but it actually works, or just being slightly overweight. So why have we got here? Why have we got to this stage? Well, probably lifestyle, lots of convenience foods, getting into cars and going places. Even if you look at school children, a lot of school children would be dropped at the school gates now rather than perhaps cycling or walking. Reduced exercise. We all buy our gym membership in January, but actually how much do we use it? Knowledge around foods, and that's been really interesting working with women actually around their knowledge of food groups and what's good foods, what's bad foods. And the theory that keeps coming up is around genetics. Well, actually my family are all big, so I've just followed my family. But is that chicken or egg? Is it that their lifestyle is such that they all look the same eventually? So, this is the fat map in the UK. I don't know whether you've all seen it, but you've probably all gone to exactly where you live now. I come from Wales, and you can probably see why I'm doing a lot with obesity, because we're that little sore thumb on the side. So the future, and this was a survey that was done between 2005 and 2006 for 15-year-olds, and I think this is quite scary. And you've just got to look at children walking down the street, and for midwives in this room, these are the people that are starting to come through our service now. We're seeing them. And actually, it's not just about health, it's about the impact of the NHS as well. So this is 15-year-olds who, at that point in time, usually have a majorly big body image as well. But actually, we're right up there. Well, Wales is definitely right up there. And this is the obesity trend across the world, so different areas. And we always think of America as being the place that there's an obesity epidemic going on. But actually, we're not that far behind. So I think we need to sort of sit up and listen now. In 2007, so a long time ago now, it's coming up to 10 years now, the Foresight report came out, which stated that by 2050, 60% of men and 50% of women could be clinically obese. Again, you know, with the NHS in the situation it's in at the moment, you know, that's going to have a major drain on resources. And without action, they said that obesity-related diseases are estimated to cost up to, about £50 billion per year. They said that the obesity epidemic can't be prevented by individual actions alone, and that we actually needed a multifaceted approach. And I think this is across all areas, whether it be education, social care, health, we all need to work together to try and enable the obesity epidemic to go. And that involves changes not just at political levels, but also personal, family. Fits into very much what Benjamin was saying about earlier on. So all of those different levels. And again, it's a political beast. We need to get in there. Fits in with the food agencies, with food consumers. So is it an issue in pregnancy? Unfortunately, yes. In 2005, they said that 1 in 5 pregnant women in the UK are obese. Actually, now it's probably 1 in 4. And that was from the CMACE statistics that did a national survey a few years ago. Obesity is linked generally to poor health outcomes and also pregnancy complications. And we know that retaining weight gain following pregnancy can lead to long-term obesity. So it's not just about the impact on pregnancy, but it's that impact later on. And how many times as midwives have we heard people say, oh, I gained 4 or 5 stone in my previous pregnancy. And actually, that's not that easy to lose. You might read a lot of the magazine articles where a lot of the stars have got personal trainers and get back to their pre-pregnant size, but actually we're not all able to do that. And we know that excess maternal weight gain during pregnancy is associated with obesity in children at 3 years of age. So actually it has a huge impact, and there's a lot of studies at the moment going on around placental markers and obesity. So the health implications, and there is a lot of research to show that obesity has got health implications linked with it. I think for any obstetric service, if you've got a medical clinic that runs, you've just got to walk into that medical clinic to actually look at the size of women that are in there, and you'll know that actually it is linked to a lot of the medical conditions. So things like hypertension, gestational diabetes. We know that there's an increased emergency and elective caesarean section rate. Now, this can be for different reasons. It could be that the gestational diabetes or the hypertension has become uncontrolled, so actually you've decided that you need to deliver this baby early. Or it could be that you're not sure about the size of the baby and you're worried about things like shoulder dystocia, so you actually then decide that you're going to deliver this baby by elective section. Increased induction of labour rates, and we know that there's quite a lot of failed induction of labour because the uterus actually is made up of layers of muscle, and if there's fat there as well, there's fat in between so that the uterus doesn't contract as well. Increased rates of venous thromboembolism, and our awareness around making sure that we control for that, and increased risks of postpartum PPH, so postpartum hemorrhage, with quite vast amounts of blood loss as well. For baby, shoulder dystocia is probably one of the biggest ones, and this is because we've got to remember it's not just the fat that we can see on the outside, but actually internally. So quite often your outlet, your pelvic outlet, may be less because there's a lot of fat around the vaginal walls, so you may have a biggish baby and also then have problems with delivery. Preterm birth, and again this could be because you've needed induction, but also we've shown that preterm birth can be spontaneous as well. Admission to neonatal unit, and again that can be linked with maternal health. Birth defects such as spina bifida and omphalocele, and there's some recommendations around vitamin D in pregnancy for obese ladies as well. Stillbirth, and I think stillbirth is one of the really sad implications of obesity, because quite often mums can't feel fetal movements. So that first detector of being able to tell whether a baby's not well, we actually can't pick up because mums aren't feeling those movements. And that used to be quite a rare occasion for me as a midwife before, that mums would come in and say, I don't really ever feel fetal movements. And now it's becoming more common. And macrosomia, so big babies related usually to gestational diabetes. So are we prepared, and at what cost? There's been a lot of surveys to show that actually obesity is causing a massive drain on resources in the NHS. And that's for lots of different reasons. It could be prolonged lengths of stay, whether for mum or for baby, but also around equipment as well. And I don't know whether in your unit you know, access to things like bariatric beds, bariatric wheelchairs. Is your operating table big enough for ladies? So when you've got that lady with a BMI of say 58, 59, which unfortunately we've seen in our unit, have you got the equipment that's suitable for that lady? And quite often do you decide to do an elective section because you think, well, actually, then at least we know we've got personnel around at the time, but what are the risks to that woman? But also we know that women with a BMI of 29 and over have an increased hospital stay of about 4.5 days, so that's quite a long time. So there has been some guidance in this area. If we look at weight gain in pregnancy and what's recommended, unfortunately the UK still hasn't got any recommendations on that. I know when the NICE public guidance came out in 2010, I got very excited and thought, yes, we're going to have an answer now, but there was nothing in there. So I know in my unit, and I know a lot of units across the UK, we go by the IOM recommendations around weight gain in pregnancy, because that's the only ones we've got to go on at the moment. CMACE also in 2010 worked with the Royal College of Obstetricians and Gynecologists to look at management of women with obesity in pregnancy, and this for us in Cardiff has definitely been our blueprint of the care that we now give for pregnant women, and it's actually a very quick list of things that is a bit of a tick list if we got this in place. And then NICE have got some public health guidance mainly related to weight management before, during and after pregnancy and what the inputs are there.